Good day to all of you. Thank you for joining us at APICS 2020. My name is Jensen, and I'm an anesthesiologist and intensivist at Tan Tock Seng Hospital, Singapore. Welcome to the lunch symposium brought to you by Pfizer on the theme of treating critically ill patients in an era of increased gram-negative bacterial resistance, challenging the standard approach. Now, before I introduce our distinguished speakers, let me quickly point out to you that you may key in your questions on the Q&A function. Do I have to? So without further ado, I'd like to begin by introducing our first speaker. We have two fantastic speakers today to help shed light on the issue of MDR, multi-drug resistance gram-negative bacteria. First, we have Dr. Asok Kurup. Dr. Kurup is an adult infectious diseases consultant at Infectious Diseases Care Private Limited at Mount Elizabeth Medical Center and a visiting consultant to the Department of Infectious Diseases at Singapore General Hospital. He was a former visiting consultant at the Communicable Diseases Center, Tan Tock Seng Hospital, where he ran outpatient HIV clinics. He was also a former teaching faculty at the Yong Loo School of Medicine and Duke's Graduate Medical School. He is the current chair of the Antibiotic Stewardship Committee of Parkway Hospitals and the Chapter of Infectious Diseases Physicians of the Academy of Medicine, Singapore. Without further ado, I'd like to hand over the time to Dr. Asok. Dr. Asok, please.
Thank you very much, Jensen. Can you hear me loud and clear?
Yep, can hear you.
Okay, I'm going to... All right, can you see my slide?
Yes, you can see your slide.
Okay, let me see if I can move my slide. Okay.
Yes. Now,
so thank you to Pfizer for allowing me to talk. Well, I have the pleasure, but also the topic is rather grim because my topic is on the implications, the rather grim implications for multi-drug resistant gram-negative infections. So I'm going to call it MDROs in critically ill patients in Asia. And so it will also serve as a little segue into Dr. Kenneth Chan's talk coming up after mine. So here are just a few of my disclaimers. Okay, so my outline will be that I will just introduce a brief on the epidemiology of MDROs, particularly the gram-negatives, because that is now our current bugbear in Asia. And in the discussion, I will go through all the organisms of interest as listed. I will talk about the impact of these multi-drug resistant organisms, and finally come to some of the many challenges that we have in terms of diagnosis. So to give you the initial perspective on extended spectrum beta-lactamases, here you have WHO data on what the prevalence of ESBL producers amongst E. coli isolates are in 2014. And when you look at the world map, and you can see in red problems mainly in India, in China, on the burden of ESBL, both for Klebsiella as well as for E. coli. And you can see that we are not too far off in that regard. And, you know, Asia has one of the highest rates of third-generation cephalosporin-resistant Enterobacteriaceae. And unfortunately, the incidence of ESBL infections are also increasing in the community, with fecal colonization rates amongst healthy individuals in some areas being 14% or higher. So when we talk about extended spectrum beta-lactamases, we have now this entity called the CTXM, and the CTXM have become a global standard, as it were. It's disseminated all over because it's plasmid mediated. So, you know, it's highly transmissible. And this variant of ESBL actually has a lot of resistance phenotype, in particular to quinolones as well as to aminoglycosides. So there's very restrictive in terms of what kinds of antibiotics that you can use. And predominantly this will be carbapenems, which then sets the trend for carbapenem resistance, which will be a no-brainer because a lot of times we end up having to use a lot of carbapenems because of the high ESBL prevalence. So just to give the uninitiated a little 101 on ESBLs, these are enzymes that inactivate and confer resistance to all the beta-lactam classes of drugs, the penicillins, the cephalosporins, the aztreonams, but then it's still susceptible to the carbapenems. And some recent data, which I'll show you the reference in a later slide, that amongst Enterobacteriaceae causing hospital-acquired infections in the intensive care units in Asia, almost 60% of them were ESBL producers, particularly when it came to VAB or bloodstream infections. So this is what it looks like when we look at a large database from 1997 to 2016, looking at multi-resistant Pseudomonas aeruginosa across many regions of the world. And when we focus on Asia, which is in blue, you can see the overall trend is that we are approximately 20% of all our Pseudomonas aeruginosa are multi-drug resistant. Of course, not as bad as some areas of the world like Latin America, but you can see that most of the world is suffering in this regard anyway. And the same goes for extensively drug-resistant Acinetobacter, one of our big bugbear in the ICU. A lot of times Acinetobacter follows this rule. It's either going to be multiply susceptible or impossibly resistant. You will not find an Acinetobacter that is in the middle. And unfortunately, most of the time, if you were to look at this database going from 1997 to 2016, and if you look at Asia Pacific in blue, you can see we are in the 60 to 70% range, much as what is being experienced for a lot of the world as well. Now we move on to carbapenem-resistant Enterobacteriaceae. But before I take you on through that, just a little bit of definitions, because a bit of confusion when we talk about CRO, CRE, and CP-CRE. So what do all these mean? Well, CRO refers to any carbapenem-resistant organism. So, and that organism can become resistant to carbapenems by a variety of ways. It could be a mutation, it could be an inherent resistance, or by production of carbapenemases. So when the resistance is established due to carbapenemases, then we call that organism a carbapenemase-producing organism, or a CP-CRO. Now, when that organism is an Enterobacteriaceae, we call that a CP-CRE. So simply put, if you have carbapenemases, it means that there's broad resistance to most of the beta-lactams. So unlike the ESBLs, this also includes the carbapenems. So that becomes a big problem as to what we can possibly use to treat. And then there is this classification of carbapenemases to the left of this slide, which is basically encoded by plasmids. So again, highly transmissible. And you can divide them according to certain classifications: the serine beta-lactamases class A, C, and D, and the metallo-beta-lactamases class B. So when we look at class A, B, and D, they are predominantly resistant to carbapenems, C to cephalosporins as well. On the right of this slide, you will notice an algorithm, not to get confused by it, but it is just to give you an idea that when we have a carbapenem-resistant organism, be it the CRE on the left or the CROs, which we defined earlier, it matters whether or not they are producing carbapenemases or not. So whether they are CP-CRE or CP-CRO, and that's why I defined them earlier, because once you know what kinds of mechanisms of resistance they have, whether it's KPC or whether it's NDM, it's going to impact on what kind of therapeutic that you can use. For example, ceftazidime avibactam, it's useful as a therapeutic when it comes to an organism, a CP-CRE, that is expressing OXA48 or KPC. So just to give you the world perspective on carbapenem-resistant Enterobacteriaceae with regards to the NDM phenotype, and you will see that most of the world's endemicity is seeming to be in the South Asian context of India, as well as in South of Asia, but the rest of the world not as bad. But if you look at the map for KPC, however, you can see that it is far more disseminated in America, South and North, as well as in China and parts of Europe. So even though the KPC producing Enterobacteriaceae came on later, approximately 2 years after the detection of NDM, it has become the predominant carbapenemase type in circulation globally. Now, very often we have this problem as to what the resistance might be in your kinds of patients, where they're coming from, etc. And I just wanted to introduce this particular website for you. It's called the Center for Disease Dynamics, Economics and Policy. And this is the information that you can use to Google them. And basically you can choose whichever organism of interest, and they will give you what the prevalence of that is. So all these kinds of information is already available. So, you know, it's very important to know where your patients come from, and so that you know what kinds of resistance trend there is for that organism from that part of the world. Now, honing into Singapore, what kinds of problems do we have here? So this is a little paper out of SGH from my colleagues, not too many years ago, discussing carbapenem resistance in gram-negative bacteria. And so you can see our major problem with Acinetobacter in blue in that 50% or 60% category. And then, you know, most of our Enterobacteriaceae with regards to E. coli and Klebsiella, around about 7 to 10%, Pseudomonas about 10%. And this is dated about 4 or 5 years ago. I don't think there's a big difference by way of Enterobacteriaceae in that regard. But this is looking at data that came up from colleagues in Tan Tock Seng, working together with others around the whole island. And we looked, I think I was involved in this as well, where we looked at carbapenem-resistant Enterobacteriaceae from 2010 to 2015. Now, we actually had an initial rise over the years, but with a lot of infection control measures, we managed to get the incidence of clinical cultures of CRE. This is the black line that you see. It started to dip around 2015 or so. But screening cultures, because we are doing a lot more screening, it started to come up. So hence you see the dichotomy. But if we were to express in color over here, it becomes more clear that the numbers of the carbapenemase producers as a function of all carbapenem-resistant organisms, about 75% of them are carbapenemase producing. So that's the kind of data that we have. So for you to remember that a lot or a majority of carbapenem-resistant Enterobacteriaceae are producing carbapenemases. Now, what kinds of carbapenemases do we have here in Singapore? Well, Singapore is experiencing a co-circulation of all three dominant ones, KPC, NDM, and OXA, because we are a regional hub for tourism and for business. So we have been appreciating all three phenotypes. So we cannot say it's all KPC or it's all NDM or one way or the other. We have to know which one we are dealing with. Now, having had that kinds of background, you and I have come across many kinds of data like this, including mortality that tells us that, you know, it's associated with initial inadequate therapy in critically ill patients. So basically, you know, you want to make sure that you get the appropriate antibiotics in early. Now, you need to make sure you do that so that you get less of a problem with mortality. However, this is again Asian data telling us that for multi-resistant organisms with hospital-acquired infections amongst patients in Southeast Asia, there's a lot of excess mortality when it comes to drug-resistant organisms. So we have to overcome that. This is data showing carbapenem-resistant Enterobacteriaceae, and you can see that association with mortality. So what can we do better? We have to understand what our local epidemiology, antibiogram, we have to diagnose better. We have better drugs maybe, and that's a subject for the next discussion, but important to have very good stewardship programs, because it's very important that we get these measures appropriately designed for our patients in the ICU. The CRE risks in Singapore, if we were to define who are at risk in Singapore for CPCRE, and this is again data getting from the same group alluded to earlier, male, gender, ICU stay, hospitalization in the preceding year. So these are the kinds of local data that we appreciate for people who might end up getting CPCRE. But if you look at the typical risks of people with multi-resistant organisms, you can see that there's a lot of overlap between people who might have any kind of multi-resistant organisms. So it's critically important that we understand that this is the kind of data that it needs to be looked at, particularly if you're looking at travelers who come from India and Pakistan, that they might be having an NDM. But you must know what your local epidemiology is, and very important to know prior colonization. So you need to have very good lab support. And that is in regards to many things that we can do nowadays, because what I would like to say is the beginning of the end of empirical treatment, because we have good new diagnostic tools that we should rely. And this slide tells us that the good old, bad old culture methods where you get your reversion, in 2 to 3 days can be decreased tremendously with new types of technology using PCR techniques and tools. And one of these is the fact that you can confirm the presence of carbapenemase genes. And if you know that, that can be given to you in a matter of hours, and that can help you design your therapeutics. Because as mentioned, if you have KPC, you might choose an organism, you might choose a therapeutic that may be including ceftazidime avibactam. But if you have an MBL, then you might have to choose a combination of colistin-based regimen or one that contains ceftazidime avibactam aztreonam, for example. I mean, these are guides. We have many tools in our hand, but in the interest of time, let me take you them very quickly. We have the respiratory pneumonia panel, where you can look at many different types of viruses and bacteria. You also have the hospitalized pneumonia panel that can detect simultaneously pathogens as well as antibiotic resistant genes. And the turnaround time is very, very short. And these are the kinds of organisms that can be detected as well as their resistant markers. We have the blood culture molecular assay, which can give you the answer within a few hours as well, so that you know what kind of organism that is way before your cultures flag it. And finally, this is an example of a therapeutic algorithm that people can use in their ICU. It's not a one size fits all at all, but if you have a complicated infection in the ICU, for example, a pneumonia, and you find out whether or not that person has received previous antibiotics or not, or whether it's a VAP, and you look at kinds of your local antibiogram to know what kind of risk factors that they might have for Pseudomonas, KPC, and then you can then design your antibiotics appropriately. And if you have those novel technologies that I discussed so that you can diagnose better, that's going to be even more helpful, so that you can then tool up and find out what's the best way you can treat a KPC or an Acinetobacter or an NDM-based organism. So finally, my take-home messages for you that we have in Asia a high rate of gram-negative MDRO, and some examples are illustrated over here, terrible rates, unfortunately. The impact is that delays in initiation of appropriate therapy, it's going to be bad for the patient, but if we use a lot of second-line agents with inferior bactericidal activity, unfavorable PK/PD, we're going to risk a lot of adverse patient outcomes. And unfortunately, this risk is amplified in ICU patients. So we need to know our at-risk patients. So rapid diagnosis of CPCRE resistance genes is vitally important. We have to engage new tools in a timely manner. And we have to, of course, have overriding governance with regards to all these, and with regards to appropriate antibiotic stewardship, and last but certainly not least, infection control measures as well. So that is it. That's my talk in a nutshell. And I'm sorry if I took up a couple of minutes. I would like to now end my talk, and I'm happy to take questions later. Thank you.
Thank you, Dr. Asok, for that very informative talk. So just a quick reminder that you may submit your questions via the Q&A function of the Zoom screen, and we will try to address the questions at the end of both talks. So next up, we have Dr. Kenneth Chan. And Dr. Chan is a respiratory physician and intensivist in private practice. He is a founding partner of Respiratory Medical Associates, which is a group of respiratory physicians and intensivists with offices in Gleneagles, Mount Elizabeth, and Mount Elizabeth Novena hospitals. Dr. Chan completed his advanced specialty training in respiratory medicine at the Singapore General in 2002, and he also completed a clinical fellowship in critical care medicine at the University of Toronto in Canada in 2005. He is a past president of both the Singapore Thoracic Society and the Society of Intensive Care Medicine Singapore. He is currently the vice chair of the chapter of intensivists of the Academy of Medicine Singapore and an adjunct assistant professor of medicine at the Duke NUS Medical School. So all yours, Dr. Chan.
Okay, thanks very much, Jensen, for the kind introduction, and thanks to Pfizer for sponsoring this whole conference as well as this lunch symposium. I'll just get right down to it. I will follow up on Asok's talk in basically in the next 10 to 15 minutes or so, talking about some of the options we now have for these terrible MDRO organisms. So a disclaimer slide, just the usual disclaimers regarding antibiotic dosage and off-label use, and some conflicts of interest sites. So I've received honoraria at board and speaking engagements for all of the following companies. Okay, so as Asok had already mentioned, we are now in a very bad situation where we are losing the effect of some of our broader spectrum antibiotics to some of these organisms, to the extent that the World Health Organization has listed the organisms that were mentioned in Dr. Asok's talk as Acinetobacter baumannii, Pseudomonas, and Enterobacteriaceae as priority one in terms of allocating resources for trying to find new molecules. Okay, for most of these organisms, our treatment options are really limited. We are limited to using toxic and difficult to use antibiotics such as the polymyxins or the colistins, as well as the aminoglycosides. So what do we actually have? I will start by talking about one of the molecules that were one of the first marketed molecules that is very has good promise. Okay, and it is basically avibactam, which is a novel beta-lactamase inhibitor. So the old beta-lactamase inhibitors were good against mainly the class A beta-lactamases. But unfortunately, they were not very good once you were dealing with an organism that was expressing an extended spectrum beta-lactamase, such as a class C beta-lactamase, and they had almost no activity against class D, and as mentioned earlier on, the metalloenzymes. So avibactam is a relatively new molecule that kind of help to overcome some of these beta-lactamases. Prior to avibactam, I guess we had the carbapenems, okay, to help overcome ESBLs. But even then, as mentioned in Dr. Asok's talk, we have lost the activity of the carbapenems because of all these carbapenemase producing organisms. So avibactam has activity, can inhibit the KPC carbapenemases. It has activity inhibiting the MC and some activity against OXA48, which is one of the carbapenemases. It doesn't have activity against the Metallo-beta-lactamases, those are those that are produced by, for example, Acinetobacter baumannii and some strains of Pseudomonas aeruginosa. So when we combine avibactam with a very well-established third generation anti-pseudomonal cephalosporins such as ceftazidime, you can see now in this fairly busy table that we now have at least recovered some of its some activity against carbapenemase producing organisms as well as ESBL organisms. And if you compare, let me just pull up a pen here. Okay, if you compare the spectrum of meropenem, for example, which was for a long time our go-to very broad spectrum antibiotics when we were dealing with a fairly resistant organism or an ESBL organism, we have at least recovered activity against KPC producing organisms as well as OXA48 organisms. So ceftazidime avibactam seems to be pretty good against carbapenemase producing Enterobacteriaceae, some strains of Pseudomonas, more so than meropenem. And again, as mentioned earlier on, unfortunately, it doesn't really have much activity against Acinetobacter baumannii, or primarily because these produce metallo-beta-lactamases. That is a very good trial portfolio of 7 prospective international multi-center randomized phase 3 studies that looked at ceftazidime, avibactam against a spectrum of infections that we commonly encounter in the ICU, including complicated intra-abdominal infections, complicated UTIs, adults with ceftazidime resistant bacteria, and also pneumonia. All of these have some similar features. The comparator is primarily against carbapenem, either meropenem or doripenem, although in the reprise trial, the comparator was best available therapy. And all of them were designed as non-inferiority trials, and all of them were consistent in that they demonstrated non-inferiority to what we consider the broadest spectrum antibiotic available at the moment, which was a carbapenem. Just as an example, so this is the recapture trial, which was a phase 3 randomized control trial that compared ceftazidime avibactam versus doripenem for complicated urinary tract infections. These included acute pyelonephritis, renal abscesses, and even bacteremia. And you can see that in terms of the endpoints, all of them were favorable and if potentially even numerically superior to doripenem. So for example, in the combined patient-assessed symptomatic resolution and microbiologic response at test of cure, the percentage of patients in the treatment arm that responded was 71% versus 64% in the doripenem arm. So those were the 7, I guess, phase 3 registration trials. What about real-world data? Since the publication of those trials, there are lots and lots of publications, more than 17 studies, mainly of 3 differing categories. They were either single center or multi-center. Some were retrospective, some were prospective observational trials, some were used as where ceftazidime avibactam was used as first line because of risk factors for resistance or because of particular local situations, such as the antibiogram of the particular ICU. Some were administered ceftazidime avibactam as rescue therapy when either the patients were not responding or a very resistant organism was isolated. This is just one example of a single center trial of 38 patients with a lot of comorbidities. They were primarily infected by CRE caused by KPC and OXA48, both of which are carbapenemase producing genes. And 95% of them had received some antibiotics prior to being switched to ceftazidime-avibactam. So this was in the context of a salvage therapy. And the good news is that 3/4 of these patients had either clinical or microbiologic cure, thereby emphasizing that this is really, in the real world, a very, very viable treatment option for patients that are infected with CREs or carbapenemase producing organisms. Another study, another single center study, primarily Klebsiella pneumoniae, E. coli, most of them are CREs, okay, in 77 patients, a gamut of different infections, from bloodstream infections to intra-abdominal infections to UTIs, soft tissue infections, and pneumonia. And you can see here that the survival rate at day 30 was 81%. More than half of them had clinical success. The lowest rate of success seemed to be in the pneumonias, and I will maybe kind of expand on this a little bit more on why this is happening. In the interest of time, I would is another real-world study of salvage therapy infections caused by carbapenemase producing Klebsiella pneumoniae. Again, a positive study when using ceftazidime-avibactam. What's interesting about this study was that Zafisefta or ceftazidime-avibactam was primarily used as monotherapy. Okay, there had been some concerns about acquired resistance by some experts. So this is a small signal that if used appropriately, it's possible that monotherapy would be enough. So in my personal opinion, when are the situations when you would consider ceftazidime-avibactam? Obviously, in the patients, if we know that they are colonized either through admission screening protocols with Enterobacteriaceae strain producing KPC or OXA48, or if you're working in an ICU where there's a high prevalence of CRE or ESBL producing Enterobacteriaceae, okay, especially if they've used carbapenem or colistin before, they are severely ill, and they're immunosuppressed with multiple comorbidities. And obviously, if you, after your cultures or through PCR techniques, you isolate a gene or an organism that is producing a carbapenemase. Okay, a quick blurb about some of the other considerations in the ICU. So many beta-lactams and ceftazidime included depend on time above the MIC in order to achieve a very optimal bactericidal activity. And the time drug concentration above the MIC, and we typically want it above 50% to be predictive of antibacterial effect. Okay, so some of the traditional methods with some of our older antibiotics was either dosing the antibiotic more frequently so that we achieve a lot more time above the MIC, or using higher doses, or extending the infusion. So instead of typically your 1 hour or 30-minute infusion, extending the infusions to 3 hours, 2 to 3 hours or so, helps to maintain the drug concentration as long as possible above the MIC. I guess the conflicting consideration would be that ceftazidime is renally cleared, and hence in many of our sick ICU patients with acute kidney injury, there's a need to renally adjust the dose to dose down. And this is not always easy because renal function can be fluctuating. There is a very high volume of distribution in our septic in our septic and very hyperdynamic patients. There is a lot of fluid loading that's involved, and many septic patients also have augmented renal clearance. So trying to dose optimally is really kind of a moving target. And I'm just showing this recent publication from last year where, and in the original phase 3 trials, namely RECLAIM 1 and 2, one of the things that came out of the study was that in the patients with moderate renal impairment, the clinical cure rate was actually inferior to the comparator, which was meropenem. And it was thought that perhaps in the setting where the renal function is fluctuating or maybe improving fairly rapidly, maybe it was under dosed significantly. There has since then, looking at this paper, as well as simulation studies, as well as probability to target attainment type studies, very comprehensive dose ranging studies. Since then, in the drug label, the dosing had been adjusted upwards. So for example, in moderate renal impairment, the patients are dosed 1.25 grams Q 8 hourly now instead of 12 hourly, and so on and so forth for severe renal impairment. And in order to further optimize the PK/PD characteristics, infusion is always over 2 hours and not in the original phase 1 studies, just over 30 minutes or so. So in summary, when we compare Zafisefta versus some of the other older beta-lactamases such as piptazo, you will find that the efficacy is a lot more broader. What about other options? In the interest of time, I'm just going to probably zoom through these slides, but just know that in addition to ceftazidime avibactam, there's also ceftriaxone tazobactam. That's the other mainstream newer combination cephalosporin and beta-lactamase inhibitor that is available. This seems to be ceftriaxone with a high affinity for penicillin binding proteins, and it has activity against many of the mechanisms of resistance for Pseudomonas. So it seems to be a very good option for a resistant Pseudomonas aeruginosa. But again, unfortunately, it doesn't have activity against the carbopylases, so it's still not very good for the carbopylamase producing Enterobacteriaceae. There's a whole list of others. Almost all of these at the moment are in phase 3 trials. Many of these are not registered for use in Singapore. What's very promising is federalcode, which has activity against many resistant organisms, including the metallobacter-lactamases. So this is potentially a very good drug against some of the organisms that's not covered by Zafisefta. This includes Acinetobacter, Stenotrophomonas, and Maltophilia. Okay, so I'd like to conclude by saying that ceftazidime avibactam is one of the first marketed, very good activity, an important treatment option against MDR Gram-negatives, especially the CRE, except for the MBL producers. For Pseudomonas, we have ceftriaxone tazobactam or Zafisefta. If you do isolate a Pseudomonas though, it's potentially ceftriaxone tazobactam is better. We still have problems against Acinetobacter baumannii, but there are a number that are molecules that are now in phase 3 trials, and we look forward to using some of them for this very resistant organism. And finally, more research is still needed regarding, I guess, how to dose many of these drugs effectively in a very challenging PK/PD environment, such as a critically ill ICU patient. And with that, I'd like to thank you very much for your attention, and I guess we'll stop here for questions.
Thanks very much, Dr. Chan. So in the interest of time, I think Dr. Asok has already answered the question on Q&A, but I'd just like to pose one clinical question to both our speakers today, since our theme today is about challenging the standard approach to treatment of multi-drug resistant organisms. Now that we have some information and access to a newish kind of antibiotic, I'm just wondering what your thoughts are about reserving this new molecule for targeted therapy versus using it empirically for patients, and if empirically, in what situations would you use it in? Maybe I'll start with Dr. Asok.
Thanks, Jensen. Can you hear me now?
Yep.
Yeah, all right. So it's a very practical question because, wearing the hat of antibiotic stewardship, it's always important that we don't, as you mentioned, waste the molecules of novelty, and then we are back to square one with all the drugs. So we have got this eternal conundrum, but it's also very important that, we take care of the patient at risk. So we have those different algorithms, different people with risk factors. So, when we have medical transfers and evacuees who come from overseas, we actually screen them. And when we do the rectal screening, etc., we actually already know who has what kind of organism from the outset. So these are people with prior colonization, and when they become, or if they become septic, then you should already start to plan to cover that organism regardless, because while you wait, so that's already one of our practical to-dos. And in addition to that, we engage a lot of novel, faster diagnostics, as we alluded to rather briefly though. But anyway, we try to get as much of that kind of objective data so that we don't misuse these agents. Having said that, if somebody has had a history even prior that they had CPCRE a few months ago and they are septic again, I don't think we should lose that opportunity. We should treat. And, there is enough data to say that in ICU, you should treat aggressively and then de-escalate rather than the other way around. But we shouldn't be too empirical and everybody who walks through the street gets a broad spectrum. That's not the idea here. So that's where I think that we have to engage antibiotic stewardship programs, especially in the ICU, to make sure that we don't get into that hole.
Thank you, Dr. Asok. Does Dr. Chan have anything to add?
No, I concur absolutely with what Asok has mentioned. It's a very difficult tightrope and balancing act. And what, at least in my own practice, I've tried to do to try and in a way limit the use of some of these newer antibiotics is to try to leverage, other than looking at demographic and clinical risk factors, really leverage on and some of these newer PCR techniques. So for example, in the pneumonias, I do have a low threshold for sending off one of these respiratory panels or univiral panels looking for the Carbopylases genes, and because they can turn around fairly very quickly, literally within the day or so. If there is a resistant gene isolated, then I go with one of these beta-lactamase inhibitors or these newer antibiotics. If not, I may stick to some of our conventional broad-spectrum antibiotics that we use first. Yeah. The only thought I have probably is, I think part of the reason why we are kind of facing this is maybe there's too much of carbapenem overuse, and I just wonder a little bit about sometimes in a way as a carbapenem sparing strategy, trying to use ceftazidime, avibactam, or even ceftolozane, tazobactam as a carbapenem sparing strategy when we are dealing with ESBL, for example. So I think there are some thoughts along those lines, but at the moment, yes, I do feel that we should not be using these drugs for everyone.
So thanks very much to both our speakers. I think in interest of time, unfortunately, we will have to end the session, but I'm sure you would all agree that even though we're overrunning a bit, it was time well spent. So with that, I'd just like to thank both our speakers, Dr. Chan and Dr. Asok, for spending our afternoon with us today, and also our sponsors, Pfizer. And I hope you enjoy the rest of the conference today as well as in the morning tomorrow. So thank you very much.
Thank you.